Welcome back, everybody. Hope everyone had a nice break. My name is Shane Angus, and I have the privilege of serving on the board of APSF. Dr. Cole is stepping out to take care of a few administrative matters, and so I'll start from this section, the next section, section 2, but I did want to make sure and translate this from session 1 to session 2, where we talked a little bit about, NORA, is it all created equal? And I think we had a great double panel, if you will, covering those two topics. And so we're going to transition now into appropriate procedures in patients. And I think this will also lead to a lively discussion. We're very fortunate to have 3 fantastic speakers to cover these subjects. And so I'm going to introduce them individually and ask them to come up as a group, as we've been doing already, for the sake of time. So our first coverage is going to be on ambulatory surgery centers, and this is going to be Dr. Bobby Schweitzer. She is a dual-trained anesthesiologist and internal medicine physician. So Dr. Schweitzer, if you'd start making your way up, thank you very much. And she is also the president for SAMBA and is the systems director for preoperative medicine at Inova Health, just a neighbor of mine next door in Virginia, and is a professor of medical education with the University of Virginia. Our next speaker is Dr. Fred Shapiro, who is going to be covering office-based anesthesia. So if he could make his way up as well. He is an associate professor at Harvard University's Medical School and Massachusetts Eye and Ear. He is a SAMBA Board of Directors and the chair of the Committee on OBA. And he recently wrote some of the updated guidelines in Massachusetts to define the qualifications for practitioners supervising office-based procedures in surgery, and also recently revised the Massachusetts Medical Society's office-based surgery guidelines and acts as a resource for the ASA on these said topics. Our final speaker, wrapping things up, is Dr. Rita Agarwal, who's going to discuss the dental anesthesia, which of course has had lots of media attention in the past few years. She's a clinical professor at Stanford University in the School of Medicine, and she has been involved with anesthesia, specifically pediatric anesthesia, for well over 20 years. She served as the program director at the University of Colorado and has now moved to Stanford, where she is on the chairing of the Committee for Pediatric Education Training. She is the recent past president for the Society of Pediatric Pain Medicine, and she's a senior editor for the American Board of Anesthesiologists Certification Examination. So we're going to cover these 3 subjects here, and I'm going to lead now with Dr. Schweitzer to take over.
Thank you so much. I'd like to thank the board and the organizers for inviting me to this to participate. So I'm going to dive right in here. So these are my disclosures. I didn't put my objectives up there. I really just want to get through this in 15 minutes because I'm afraid Sean's going to be upset with me if I don't. And so just a quick joke, Mike Walsh shared with me a joke last night that if you ask somebody to do a 1-hour lecture, they can probably do it in a day or 2. If you ask them to do a 15-minute lecture, it'll take a couple of weeks to get that prepared. So who? Well, again, this is an old slide, but I think it really tells a lot. I've actually written a lot about, the utility of ASA physical status scoring. Now, we can all argue about how it's subjective and that we can differ among ourselves about it, but it's surprising that it's actually stood the test of time. And it is actually quite useful and it's easy to apply. And even veterinarians assign their patients an ASA physical status before they give them anesthesia and surgery. So if it works for the animals, it should work for us. But this just really demonstrates that overall, ambulatory surgery is still very, very low risk. I'd like to point out there that, especially for ASA 1 and 2 patients, even having high risk, quote unquote, high risk ambulatory surgeries, which increasingly we may be actually doing some of those in ambulatory settings, that is still a very low risk overall of complications. The risk doesn't start to separate until you start to get to ASA 3 patients. Now, originally, almost all ambulatory surgeries were done only on ASA 1 and 2 patients, but increasingly, I think we all know that we take care of a lot of those 3s, and of course, when you're in NORA, you're up there in those 4s and 5s, as we've heard about this morning already. When you do get to the ASA4 patients, you can see there's quite a separation of risk. But I'd still like to point out that even though there's a rise in the low-risk surgeries, you can still see that is less than 5% risk, about 3% risk. So an ASA4 patient having a low-risk surgery is still quite a low risk. But there are some situations, I think, that we are increasingly finding out that even ambulatory surgery increases patients' risk. And one of these are for frail elderly patients. Frail patients of any age, but particularly frail elderly. Just because you're older doesn't mean you're at increased risk, though age does matter. But we all age at different rates, and those are aging more physiologically rather than chronologically are at higher risk. This was, I believe, a very good, robust study of a large number of patients having outpatient procedures, relatively low risk outpatient procedures, and you can see there was a significantly higher risk of complications and mortality, which is important because we can argue about complications sometimes, but when we have a dead body, there's not sort of an argument of was that atelectasis or pneumonia. This was one of the few studies, I believe, that has shown that local anesthetic and MAC lowered the risk. Some studies have actually shown that MAC anesthesia has a higher risk that may be associated with the fact that we sometimes are doing big MACs, and we sometimes are doing MACs on patients who are quote-unquote too sick to have general anesthesia. In a different study, the conclusion was that frailty is associated with a higher perioperative morbidity, even in common low-risk ambulatory general surgeries. In that study, they showed that it was independent of age and actually independent of the type of anesthesia and even other comorbidities. So frailty itself will increase risk, but frailty also is a compounder of 4 comorbidities. There are some situations when you shouldn't be doing surgery at all. So of course you should not be doing it in a NOR location or an ambulatory location or an office-based location unless it's truly life-saving emergency surgeries. So this is just from the ASA document that indicates that we should not be doing surgery on patients soon after an acute myocardial infarction. Typically, they say 60 days, even though you can see there, even up to 90 days, that risk is significantly higher than at baseline, which on average is only about 3% for patients having significant surgeries. So I do think it's important to also apply that, if it's not a good idea to do it at all, it's definitely not a good idea to do it in these more resource-limited locations. This is a guideline or an algorithm from the 2017 dual antiplatelet therapy guideline from the ACCHA guideline, and it sort of defines clearly for us the timing of stent placement and when it's safe to do surgeries. If any kind of surgeries, no matter what the location, they still say for 30 days after bare metal stents, for 2 weeks after PCI without stenting, and they have, though, decreased for drug-eluting stents from the 12-month period that we had traditionally sort of focused on to saying now it's okay to proceed with surgeries only 6 months after placement of drug-eluting stents. They say there's even reasons that you may want to or can proceed within 3 months. However, there does seem to be an increased risk even, in that between 3 and 6 months. So they do advise that if you are going to need to stop aspirin specifically, and if you're going to proceed in that 3-month period, that maybe those patients are best cared for in a center with immediate access to one of our interventional cardiologists, who I hope is still here in the audience. Because it's all about getting that patient to a cath lab and restoring blood flow to the myocardium. And that sometimes is very hard to do when you're in a remote location. On a 16th story of some office building and doing office-based or ambulatory procedures. This is another sort of evolving topic, I think, is heart failure patients. And more we're seeing a lot more heart failure patients because as people live longer, as the cardiologists save their myocardium to some extent and do all kinds of interventional things, we have patients who are living longer and longer with poorly functioning hearts. And this was one of the few studies just published a couple years ago showing that, again, heart failure is a significant predictor even for patients having very low-risk surgeries. We don't have that much good, robust data, I think, on the risk of ambulatory surgeries. So it's really, great to have articles like this. They did show what we know already from sort of the inpatient world, which is the worse your heart failure is, the lower your ejection fraction is, the more symptomatic you are, the worse you're going to do. But you can see there the odds ratio, particularly for those with symptomatic heart failure, was actually quite high. This is a study looking at stroke and TIAs before non-cardiac surgeries. There were a couple studies that came out around the same time in the sort of mid-2000s, 2010s, that looked at patients who had cerebral vascular disease. And cerebral vascular disease is not only a marker for increased risk of stroke and cerebral vascular events, but also an increased marker for cardiac events as well. And both these studies were out of Europe, and both of them showed the same thing, that a previous history of a stroke, even in somewhat the remote preceding time, for example, 9 months earlier, increase the perioperative risk. And I thought the interesting thing about this, and I've highlighted there in blue is the risk for low-risk surgeries, and in green is the risk for intermediate-risk surgeries, and the white is the risk for high-risk surgeries. The risk you can see is essentially the same even for low-risk surgeries. And this is quite a unique finding, because for most situations, for example, those heart failure patients, those patients with coronary artery disease, their risk is definitely higher, the higher the risk of the surgery. But here, even for very low-risk surgeries, the risk of recurrent cerebral vascular events or even cardiac events in patients with previous histories of strokes and TIAs was shown to be increased. So I could go on and on forever with a lot of other comorbidities, but we're going to move on to procedures. So I'm showing you that same slide again, and just emphasizing again what I talked about before, is that as you change the risk of the surgery, then you have this overlapping with the ASA physical status scoring. So this is one of a few studies that has been in the literature, I believe, that truly indicates what the risk of surgery is, particularly for non-intrathoracic, non-vascular, non-major surgeries. The ACCHA guidelines have always, and the RCR guidelines talk about big organ systems, right? Or areas of the body for risk. But if you look at it and try to look backward, is where does this information come from that an intrathoracic procedure is significantly higher risk than an orthopedic procedure? There's not a lot of data to support that. And as we know increasingly, there's a big difference between laparoscopic procedures and open procedures. Laparoscopic procedures almost always carry about half the risk of the same organ if you do it, though, laparoscopically versus open. And then, a lung biopsy is very different than a pneumonectomy. So I did this study using the ACCHA guideline, the American College of Surgeons NSQIP database, and we applied a standard patient. We took a standard 65-year-old woman in that database who had diabetes, and we said, if we match that woman to all of these procedures, what would be the risk? And I think that I was quite surprised by some of it. For example, a lumpectomy and a mastectomy are both low risk. Not that surprising, but a lumpectomy does carry about half the risk of a mastectomy. And then certain procedures, like a TURP, is it actually an intermediate risk procedure? And if you look back, there was actually an article that Lee Fleischer published about 20 years ago showing that actually TURPs and bladder cystoscopies and biopsies actually did carry significantly higher risk. But most people I don't think of it that way. The other thing I found was really, interesting again, was, something like a total hip arthroplasty has very little higher risk than that, TURP. And then, again, looking at sort of the different risk of laparoscopic versus laparotomy, we showed that significant difference that almost always they were about half the risk if you did it laparoscopically. So I do believe if you want to know the true risk of a surgical procedure, you need to use the American College of Surgeons NSQIP database. You can go online and use this for free. It's a calculator that you must use online. So you can't embed it into your EPIC. You can't remember it the way you do the ASA physical status scoring system. And in the past, they didn't have a lot of ambulatory or NORA-based procedures. They now have increasingly numbers of NORA and ambulatory procedures, both academic, hospital-based, and freestanding. I believe to this day they still don't have any office-based data, and they don't have any ophthalmologic data. for eye surgeries, but they have pretty much every other surgery. And then you get a nice graph like this. The other thing I like about this is that we always talk about sort of risk, like what's the risk, a high-risk patient. But unless you can do something about that risk, or unless you know what that specific risk is, because the risk of bleeding is very different than the risk of thrombosis, and the risk of thrombosis and bleeding is very different than the cardiovascular risk, right? So it's very important that one has a specific risk. And sure, you can do RCRI for cardiac risk, you can do Ariscat for pulmonary risk, you can do, Caprini for VTE risk, but this gives the only calculator I know of that's from very good data, not just billing data, but very good data from a large database that gives you multiple different risk predictors. And especially, you can share it, you can email it to your surgeons, because it also speaks volumes to them, because I always remind them, this is not anesthesiology data, this is not internal medicine data, this is not cardiology data, this is your data. And so it's hard to argue with. Now, I'd like to finish up with saying there's at least one really low-risk surgery that I think we should either get out of the business of, or we should definitely not be barriers to people having restoration of eyesight. And in spite of, 20 years ago, a very large study published in the New England Journal of Medicine showing there was no utility of testing, we know we still do way, way too much testing for patients having cataract surgery. And worse yet, as the testing has actually decreased over the last couple of decades, the numbers of consultations have actually increased. So patients are being sent to their cardiologists before they have cataract surgery, which is really unfortunate. We know that patients who are blind have a much higher risk of falls and injuries and all kinds of things and isolations, and we should be restoring eyesight. This was an article that was just published, one of the more recent ones, that was out of Europe, looking at the risk of myocardial infarctions in a relatively older, high-risk group of patients, because we know these patients are old, they have comorbidities, and most of them have heart disease, and they showed no increased risk of MI when the patients had cataract surgery. In fact, there's a couple of actuarial data studies showing that you're less likely to die the day you have cataract surgery or the day after you have cataract surgery than right now when all of us are sitting here in this audience. So if you think you're going to die, run out and get some cataract surgery. Seriously, what it probably means is that, it's not the people who are sitting in the audience who could go into the ambulatory center and get cataract surgery, but what we have excluded is all those people on hospice care, all those people in the, nursing home who can't get out and get to the institution. So I published an editorial in Annals of Internal Medicine, because I think now, I'm almost preaching to the choir when I talk to anesthesia providers about this issue, because I think maybe we do get it. So I'm trying to get this out more into the medicine docs and telling them, stop doing testing and stop doing consultations and stop, arguing that you need to see patients before they have their cataract surgery. So SAMBA published a great guideline, by the way. I'm the immediate past president of SAMBA, not the past president. That must be the best title in the world, is immediate past president. It's a great organization. We published this while I was still the president last December, and I think it's a fabulous guideline, even considering that I was the first author, but I had a lot of good, help with it as well. And I think it really clearly goes through, and it goes through some very specific things, like, do you have to wait 60 days after myocardial infarction? We argue, no, you don't, actually. We do argue you should wait 30 days. Do you have to wait 6 months after a drug-eluting stents? We argue, no, you don't. You only have to wait 30 days. So you have to read it to understand why we make those arguments, but I think it's great. I just want to get one more kind of situation where I put this all together, like the high-risk patient and a surgical procedure, and say, this is a situation where it's important to look at the data. So there's actually several different studies in the literature showing that patients who need AV fistula or dialysis access do much, much better. They have better outcomes. They have lower lengths of stay in the recovery area. They have less readmissions to the hospital. And they have lower costs if they have that vascular access performed in an ambulatory outpatient center, even a freestanding center compared to a hospital-based center. And yet I think that a lot of people are like, we don't take care of dialysis patients in our center. And dialysis patients are too sick to be cared for. But I think if you combine the right patient and the right procedure with the right provider in the right place, you can safely take care of them. Thank you.
I want to, can I, yeah, okay. to thank the APSF, the Stoelting Conference, Dr. Cole, and the organizing committee for allowing me to share some of the work that I've been doing in office-based safety for the past 30 years. I talked to you about the changing landscape of office-based anesthesia. To echo what Dr. Schweitzer talked about with the dialysis patients, I'm going to show you some of the research that we've done to show you the change in landscape and what we've done initially. I've recently become a consultant for the Fresenius Kabi company. And Rich Ehrman and I, in 2009, founded this nonprofit patient safety organization, the Institute for Safety in Office-Based Surgery. And our goals at that time were to promote patient safety and outcome research, design tools and advance detection and prevention of adverse events. We were interested in collaborating with all subspecialties, educating patients and physicians, and ultimately we were trying to generate an evidence-based standard of care. So what I'd like to share with you in the next few minutes, summing up 30 years in a couple of issues that I think are near and dear to my heart, but also describe the way office-based anesthesia has changed in the past 30 years. I'll talk to you a little bit about our safeties and outcome research, a new grant that we just received with Dr. Greenberg and I for a smart assistant augmented reality technology, a Harvard Medical School patient safety elective, and that's now open to medical students, and what I see as the future direction of office-based anesthesia. Since I started, when surgeons asked me in Boston to work in an office-based surgery center, this is 1997, at that time, in 95, the ASA estimated 3 million cases. In 2005, it jumped to 10 million cases. If you look at the data now, outpatient procedures, 129 million in 2018, growing to 144 million in 2023. Offices are about 25 to 35% of the volume. If you extrapolate this, that's about 30 million cases, which is 3 times the growth in 2005. And that's what the ASA estimated. A little bit about our safeties and outcome research. In 2014, when we got together, and a group of us in the office-based anesthesia community said, we got to look about benchmarking. So we looked at all the randomized controlled trials. And what did we find at that time? There was a lack of randomized controlled trials. So we developed a consensus opinion. It was published at ANA, and we could enhance quality of care by proper patient procedure selection, provider credentialing, facility accreditation, the use of checklists, cognitive aids, and professional society guidelines. Now, this was in 2014. In 2016, everyone associated ambulatory anesthesia, non-OR anesthesia, and they grouped it all in one fell swoop. What we decided to do was see if there was a significant difference between ambulatory surgery centers and offices. And what we looked at was the NACOR data from 2010 to 2014, 180,000 office cases versus 5 million ASCs. And what we found was there was a statistically significant difference in the patient demographics, procedure types, and reported events. What's interesting here, if you look in 2013, I want you to focus your attention on the type of office-based cases: dental, otolaryngology, orthopedics, pain, and GI. Those were the most active specialties about 10 years ago. I'm going to show you the data that we just published in February 22, and you'll look at the change in the landscape of office-based cases, including what Dr. Schweitzer talked about with interventional radiology and vascular procedures. So recently, I was fortunate enough to work with Avishai Newman in Centurion Anesthesia. And they asked us to evaluate their data, and we decided to look at 90,000 patients between 2016 to 2019. What was unique about this is we decided to use their electronic medical records. Now, mind you, the electronic medical records that we're using in offices, you have to extract from administrative claims electronic medical records. And this was an arduous task. We didn't expect it to be, but it took us a few years to do this. But we did segregate into the ASCs and office-based procedures. So let me give you some snippets of what we found. This is in 2019. The number of procedures in the ASC was 31,000, about 9,000 in the office space, which about 40,000 procedures. So it was a rapidly growing practice from 2016 to 19. But you see the percentage of office-based cases was 22%. The average age in the office space, it was an elderly patient population. The ASA status was larger. And the number of procedures per physician, number of procedures per office has increased. But I want to focus your attention now, 10 years later. Recall the other slide we did with the NACOR data. If you look at the office-based cases, the top 5 procedures are now prostate biopsies, angiograms, cystoscopies, uterine fibroid embolizations, and you could add ENT procedures. So this shows you that the landscape is changing. Now, mind you, this was a practice in the Northeast. So the question you're going to ask me is, does this same practice occur in the Midwest and the West? Well, I was fortunate from my colleagues from the Samba OBA committee. I have Lee Dorsch in the audience, and I have Megan Valek. And Megan has a practice in Chicago, and she has a mobile anesthesia practice. So I said to Megan, well, Megan, I got this data in February 22. Can you show me what you do? And it's very interesting. If I showed you the slide of what her mobile anesthesia group, 50 anesthesiologists, 25 procedures, you would see Megan is doing similar things. So this seems to be the trend in office-based anesthesia. A little bit about the grant. So what we devised was that testing a proof of concept model for real-time dual interactive decision support in the perioperative period using what we called a smart assistant device. Basically, this was a video and audio system to aid in real-time decision-making for the practitioner, something like a Siri Alexa or a Google Glass. And basically, it was to help the practitioner prevent and treat patient deterioration. So here's the 5 issues of the grant. It uses artificial intelligence to perform pattern recognition, and this is based on physiologic data and the medical history. This can create a differential diagnosis, and it couples it with the best practice, and it's also linked to the cognitive aids, so the emergency checklist. Now, this smart assistant technology can be customized to provider need, whether you're in an ICU, an OR, or an ambulatory surgery center, or an office. And this software system can be integrated into Epic. And basically, as I said, it's visual Google Glass or Siri or Alexa speaking into one's ear or one's eyes, but it doesn't occlude the clinician from observing the patient. The clinician has all senses while viewing the patient. And lastly, one of the other passions, besides patient safety in the office-based setting, is I recognize, despite the fact that we think we are young, we recognize there's a whole new generation of people. So what I've done for the past 30 years, I've recognized, and I'm fortunate enough to be in charge of medical student education. So I said, what do I have to do to educate students about what are the issues that I've learned over the past 30 years? So I'm proud to say that I got a Harvard ambulatory anesthesia, but we called it a patient safety elective. It wasn't to talk to them about anesthesia, but the unique aspect of this was we were exposing students to adult and pediatric patients presenting for ambulatory procedures in the hospital, the ASC, and the office. That I want the students to appreciate the importance of patient and procedure selection. And more importantly, I want them to understand the role of the anesthesiologist that guide the performance of safe anesthesia care in the pre, intra, and postoperative setting. One of the biggest objectives also to teach the younger generation is how to interact, a multidisciplinary interaction between the anesthesia care team, surgeons, and nursing. So what do I think? What's the future direction to develop the highest quality and standard of patient care? In the past 25 years, what I've seen and what I've shown you in the literature and what's validated with other practices around the country, the landscape of office-based anesthesia has changed. It's become a specialty unto itself. The number, complexity of patients' procedures continues to grow. The fact is only 33 states have legislation, 17 states do not, 17 states have it where you can't report it, and again, proper patient selection. Which is the proper patient for the proper location? So what would benefit? I feel that the field would benefit if other practices around the country do the same research that I did in the Northeast. We do it in the Midwest and the West Coast, the Southeast, Southwest. Then we could do a meta-analysis, and that would be the best way in office-based anesthesia to develop and implement safe and efficient systems to optimize patient outcomes and minimize morbidity. Thanks. I know that's a lot of information, but I'm happy to entertain questions. Thank you very much.
Is this microphone on? Oh, okay, good. And now for something completely different. So I'm going to talk this morning about advocating for safety in dental anesthesia, and I just want to thank the organizers for inviting me to give this talk. Oh, there we go. These are my objectives. I'm not going to go over them in the interest of time. I have no financial disclosures, but I do want to let people know I've worked with a number of different organizations while advocating for patient safety. I'm going to start with the story of Caleb. Caleb was a happy, healthy 6-year-old who had an extra tooth that needed to be removed. His oral surgeon told his parents that he would need sedation and anesthesia for this. His understandably concerned family turned to Caleb's aunt, Dr. Annie Kaplan, who was at the time a surgical resident. Dr. Kaplan, assuming the dominant medical practice at the time, assured her family that anesthesia in children was very safe and that there would be someone there to monitor him at all times. After receiving midazolam, nitrous oxide, ketamine, fentanyl, and propofol, Caleb naturally stopped breathing. Unfortunately, his oral surgeon didn't start bag masking him, didn't give him any medications to reverse the effects of some of the meds that he had given. He did try to intubate him, was unsuccessful, and broke several teeth. At some point, unclear how much time had passed, 911 was called, and when the paramedics arrived, no one was doing CPR and no one was doing bag mask ventilation. Wait, what? Nobody was doing anything? Why the heck was nobody doing anything? To understand that, we have to understand who was in the room with Caleb. In oral surgery and in dentistry, there is a model called the single operator model. That term has fallen out of favor, and they call it the surgeon anesthetist model, or more disingenuously, the anesthesia team care model. Basically, there is one anesthesia permit holder who directs the anesthesia and performs the surgical procedure or the dental procedure. There is a dental assistant who monitors. This was Finley. Finley died in Hawaii after receiving what was supposed to be oral moderate sedation. So another issue within the dental anesthesiology world or dental anesthesia world is the use of confusing and variable terminology that changes from state to state. Oh, sorry, this was the wrong. This was the wrong talk. This is not the one I had replaced it with, but I'll keep going. So back to the surgeon anesthetist or single operator model. The oral surgeon or dentist performs the procedure, I just want to emphasize this, and directs the anesthesia. They have a dental assistant who watches the monitor. That sounds great, right? There's somebody watching the monitors, until you understand that the dental assistants have very minimal education or training of any sort. In order to try and make this safer, the American Academy of Oral Maxillofacial Surgeons recommends that their members use a dental anesthesia assistant. A dental anesthesia assistant has 36 hours of online education and takes a national certifying exam. That's 36 hours of online education. Sydney died while getting her wisdom teeth taken out in Minnesota a few years ago. For comparison, I just want to go over really quickly what the education levels are. So at the very basics, a dental assistant needs nothing more than a high school diploma, and then they get some on-the-job training. A dental anesthesia assistant, high school diploma, 6 months of work in the practice, and then they can take this exam and do the 36 hours of online training. California has tried to create a more robust education system, and they have a program for dental sedation assistants where they are required to be in the practice 12 months and then have on-site and hands-on education as well as an expanded curriculum that amounts to 110 hours, and they take a state examination. Compare that to a dental hygienist. Your dental hygienist has at least 2 to 4 years of education, an associate or a bachelor's degree, and a national certifying exam. Compare that to a nurse, any nurse. A nurse straight out of nursing school has at least 4 years of education and training and clinical experience, and often before they're allowed to do sedation or be involved in sedation practices, they get additional education and training. So there's a problem in the dental anesthesia world. There are different standards that are applied to the anesthesia being performed for dental procedures compared to those in the medical world. There is state-to-state variability. Every single state gets to define, every single state dental board gets to define what the qualifications are for this practice. There appears to be excessive morbidity and mortality, and there's a lack of transparency. Currently, there's very little tracking of adverse events in dentistry. This is from the state of California, and basically, you're required to report a death or that may occur during a dental procedure or may have been caused by the dental procedure, or if the patient gets urgently or emergently transferred from the practice to the hospital while undergoing a dental procedure. It's not better anywhere else. What's an anesthesia permit holder? In most states, oral maxillofacial surgeons can be anesthesia permit holders. In some places, anesthesiologists can, but not everywhere. It actually depends. You may have to appeal for that separately. In some places, CRNAs. Most places, AAs are not. Dentist anesthesiologists usually can become anesthesia permit holders. And in some situations, a dentist with some additional anesthesia training can get an anesthesia permit. This was a promotional T-shirt that was given out by an oral surgeon doing for wisdom teeth removal. He actually lost his license to practice anesthesia in Arkansas because there were too many 911 sedation-related calls. So he went over to Oklahoma, where he continues to practice and teach dental sedation techniques. Nobody knows the incidence of adverse events in dental anesthesia. Nobody. Nobody knows. You can call your state board of dentistry. No, they won't know. There are a couple of papers that have helped determine what the risk might be. One was looking at claims to the largest insurance company that insures private oral surgeons. They came up with a risk of about 1 in 350,000. Another study was a retrospective study looking at cases reported in the literature, and they actually came up with very similar numbers, 1 in about 300,000 deaths. Compare that to, and I'm a pediatric anesthesiologist, so I immediately went to the registries that I know of in pediatric anesthesia. Compare that to Wake Up Safe. There were no reported cases of anesthesia-related deaths in healthy children in over 2 million reported cases. None. The Pediatric Sedation Research Consortium is a registry of. It's a voluntary registry for institutions that are involved who report every single sedation encounter across every location and every incidence that occurs. So this is sedation in the ICU, sedation in radiology, sedation anywhere by anyone. There's a lot of clinics that are involved, outpatient surgery centers. There's office-based centers that are involved, as well as some dental offices. They had I don't guess this goes back. It's not going backwards. They reported in approximately 500,000 reported cases, there was no reported cases of serious adverse events or deaths. There were adverse events in those patients, but they were easily and successfully treated. I'm briefly going to talk about Caleb's Law. So when Caleb's family realized all of these things, with the help of their state senator, they were able to pass a law through the California Assembly that basically, amongst other things, asked the Dental Board of California to study anesthesia safety in children. The Dental Board did this and came up with 5 recommendations, asking for high-quality pediatric outcomes data that could be used for further study in the future, to update the definitions used for sedation to follow the ASA guidelines, restructuring of the dental sedation and anesthesia permit system, and then to make sure places where sedation was offered had updated equipment and records. It seemed easy enough to then take what they had recommended and codify that through the California State Assembly in Caleb's Law Part 2. We also added to that, adding a separate qualified provider so that you didn't have an oral surgeon with 2 unqualified people there to help out. And again, emphasize high quality data collection. Unfortunately, Caleb's Law Part 2 did not pass. Why didn't it pass? It didn't pass because the dental lobbies are incredibly powerful. They're very unified in their messaging, and they're very focused on kind of maintaining their standard of practice. It also didn't pass because some of the comments that were made was that doing this would limit access to care, that it makes care more expensive. Oh, and there's no proof that having a separate person providing sedation and anesthesia is actually safer in anesthesia. Well, there's also no randomized controlled double-blinded studies that using a parachute when jumping out of an airplane is safer, but we all sort of assume that is true. So they're actually, though, a little bit right, because there's continued to be, and there even before this continue to be, deaths and adverse events occurring in dental anesthesia offices or in dental offices even when an anesthesiologist was present. Michael received a shot from an anesthesiologist in Vancouver. He didn't wake up. Daisy Lynn and Owen both had anesthesiologists, board-certified physician anesthesiologists present at their care, and both of them didn't survive their encounters. Zion had an uneventful dental procedure and anesthesia, but then was taken to a room next door where he was left with a dental assistant and an empty oxygen tank, apparently. And I'm just going to read this really quickly because it is so chilling. This is a quote from his mother. The alarm went off an additional 3 to 4 times, but each time silenced by the cool smile staff member, until the staff member finally removed the monitor from Zion and stated that the device does not work on children. This is a pulse ox that she was talking about. This is happening now. This is actually happening this month. This is not just a pediatric problem. Many of you may have heard of the death of a prominent cardiologist in North Carolina undergoing dental anesthesia. His wife and a coalition of people are proposing changes in the North Carolina dental anesthesia laws. We'll see what happens with that. I would be delighted if it occurs, but I'd also be shocked if it passes. So what can we do? Because I think it's really, we're all here because we care about patient safety. Well, we start with educating. We educate everyone. We educate ourselves. We educate our colleagues. We educate our dentists, our oral surgeons. We educate other physicians, our patients, and their families. We need to collaborate with our dental state boards and our medical societies to come up with safer processes. Anesthesia is not different because it's in a dental office or being provided by either an oral surgeon or a dentist. We need to have good data collection. We actually tried presenting at the California State Board and were shot down for a great tool that would have been really useful. I am super excited about the new proposed APSF guidelines for NORA, because I think as long as we can make sure that it's very clear that these guidelines apply to every place that a sedation is or an anesthetic is being provided, and every person who's providing it, I think it could go a long way to really improving safety. I use social media. I think I urge all of you to use social media to spread the word, to educate everyone. Future lives really depend on this. Thank you.
Thank you all very much for some provocative ideas and unfortunate tragedies as well. I want to give everybody a few moments to get their thoughts together, and as Dr. Cole has the mic.
Yeah, so I have a microphone. Dr. Methencool also does, so we'll kind of raise our hands. I can ask one question that's going to be a little bit of a dilemma for this conference. So we want to have recommendations. The educational program has been about hospital NORA, about ASC type NORA, about office-based NORA, and then dental offices. Should one size fit all? Should we develop recommendations that apply to all 4 locations? Or is that not practical and feasible?
I think there could be some overarching recommendations that apply to all, but then I think that they're all very different, right? Hospital-based NORA is, right next, it may be in the cath lab. So a patient that's too high risk for a cardiac procedure outside would be perfect. That's where they are already. Where, then I think office space is even the, new frontier almost. But even with freestanding ambulatory surgery centers, I think even within hospitals, we could probably survey the people here. There's quite variability. So I think it's important to have some simple, easy, overarching rules, guidelines, recommendations, and then make it a bit more specific to, the locations, and then to the procedures themselves and to the patients.
I have to tell you, I looking at the ASA model, like what Bobby Jean just talked about with the ambulatory guidelines and then the office-based guidelines, that makes sense. But what you have to understand about the office-based community, what I described to you, when I started at Mass General 30 years ago, when I started in office-based anesthesia, a few surgeons asked me to come to a place, this is in 1997, where I was doing office-based anesthesia underground, and I recognized the safety issues. Now, 25 years later, now I'm learning from other people. There's a whole new area of office-based anesthesia. It's called mobile office-based anesthesia, or car-to-car anesthesia. And I'm not an expert in that, but I actually have gone to my colleagues in the audience, Lee Dorsch and Lee in Virginia, and she was the co-chair of the SAMA committee, and Megan is the vice chair. But these people are doing this mobile anesthesia practice. So I think that I agree with Bobby Jean in saying there's certain guidelines, like main parameters. But when you look at office-based anesthesia, you really have to take a look at this as a separate entity. And I'd be remiss if I didn't ask the experts in the audience to talk about what their issues are. But I think that if we make guidelines, it has to be for all of us. But I think it has to be for a community of people that are rapidly growing with hundreds of thousands of cases. And a lot of these patients are like the type of cases that were described with Dr. Agarwal. And this is happening. A lot of these pediatric dental cases are the mobile anesthesia practices. So those are the ones that you really have to look. Now, if you think it's just in the East, It's in Virginia, because I went with Lee. I went down to Virginia and we did kids. And then I went to Megan in Chicago, and she has a mobile anesthesia practice. Another one of our colleagues, Philip Yen, is in San Francisco. His practice, children, 6 to 3 p.m. every day, 6 anesthesiologists, and they're booked until 2024. So I'd be remiss if I didn't tell you there has to be a separate set of guidelines, because this is a subspecialty unto its own.
I just want to say, I'm still at the very basics. I think we need guidelines that say you need to have at least 2 people who know how to resuscitate a patient that you're anesthetizing in the room. So I think a set of overarching guidelines with basic principles of safe sedation and anesthesia care in any location, wherever you're doing it. Because the bottom line is, whether you're getting a ditzel taken off your finger or a tooth pulled, your body is going to react to anesthesia the same way. It doesn't matter who's giving it, whether it's a dentist or whether it's an oral surgeon or whether it's a CRNA or an anesthesiologist. So I would start at the very basics. I don't disagree, and I think there are definitely, and I've spent a lot of time talking with Lee and Megan to get a better sense of the mobile anesthesia world. It's fascinating. But I think there does need to be, there just isn't really anything out there that says, the dental world is very different. Very, very different. And the things that they think apply to them versus apply to the rest of us who practice medicine. The House of Dentistry is not the House of Medicine, and they're very clear about that. Things like patient safety and quality improvement, they're still where we were 20, 30 years ago. So I feel really strongly that there should be a set of at least overarching principles that needs to be clearly stated. If you're giving an anesthetic or doing a sedation, all of these things should be placed. And it's nothing more than some of the ASA guidelines, pulse ox, EKG, somebody who understands what those numbers mean and not just watching a monitor and says, oh, the squiggle has changed a little bit now. So yes and no would be my answer. I think, yes, we should have a broad set of overarching guidelines, and then there probably needs to be separate guidelines for different practice styles.
So I think many of the things that you talked about are dear to our hearts. And obviously, we're moving in the right direction with a lot of these principles and concepts. So my question to you is, many of the things that you talked about will result in horizontal expansion of anesthesia needs in a world where we're having a hard time staffing our current locations. That's just the reality of where we are. So my question to you is, are any of you concerned that we're actually going to start to move backwards from some of these principles? Because, if I'm an oral surgeon out there and I have to decide whether I'm going to use an anesthesia service or not, and I can't get one, I might actually think about just doing it myself again, right? And so does anyone have any concerns that kind of the lack of anesthesia staff in the country is going to cause a little bit of a reversal of kind of some of these initiatives that we're moving towards?
I'm a little concerned that we need to message that not everybody needs anesthesia. I mean, really. Like, I do a lot of ambulatory, I do a lot of sort of anesthesia for cataracts and endoscopies, and I think if you compare what we do in the United States to other countries, we just use it we do an excess of procedures, we do an excess of anesthesia. And so I think we need to maybe align it a bit better and give care to those patients who really benefit from it and realize that it can be harmful, and educate the public better about what is safe and what isn't. And you don't have to be unconscious to have your teeth cleaned. I mean, my daughter, went to the dentist and he offered her anesthesia to have her teeth cleaned, and it was a routine cleaning. So I don't know. I do think but that shouldn't stop us from, really advocating for what's safe and what's not, and the proper training, because maybe anesthesia assistants can do monitoring, if they're trained properly. dental assistants, just like, anesthesia assistants do, right? Maybe they just need better training, and we need to have better standards and better oversight.
So, just to reference back to the Society for Pediatric Sedation, which has the Pediatric Research Consortium, this is specifically around sedation. I mean, that is not specifically to anesthesiologists. That's a lot of, in our institution, we work a lot with our hospitalists, with our intensivists, with our ED physicians to try and do some of the sedations that we either can't do or really, as Bobby Jean said, don't need to be there for. I do think it's increased education and increased training. I don't disagree. You could have a dental assistant or a dental anesthesia assistant or whatever you want to call them trained to do what you need them to do, but 36 hours of online training isn't it. Even 110 hours, which California offers, is probably not it. If you're going to do it, you need to do it better and need to do it well. And I think that's where our efforts should be, is in increasing education and increasing availability, and make ourselves available to help train people who are interested in getting this training.
Thank you for reminding me. Just a little caveat for this. The simulation that we're doing for the grant, one of the case scenarios we did, because there's been so much issues with pediatric dental deaths, which Dr. Agarwal talked about. So what we did was we created a pediatric dental scenario in our, using the Google Glass or the Siri or Alexa. So one of the cases involved a pediatric case that went sour. And the basic idea is using the augmented reality, artificial intelligence, to help a practitioner. Now, I was interested in this, Stephen Greenberg does ICU, and we have other colleagues that are in the OR, but I was interested in this from the office-based setting, because when you're a solo practitioner in the office-based setting, whether it's an oral surgeon or anesthesiologist, the fact is you're by yourself, and it's always good if something happens to have basically a robot, so the smart assistant technology. So our thought was, wouldn't it be great to have someone help you with the diagnosis of, clues based on the physiologic data and medical history, and suggest differential diagnosis and link it to cognitive aids. So that's one of the cases. So to echo your sentiment about educating practitioners. So we're actually doing this, and I will hopefully be invited back next year and tell you the results of our studies. But what Dr. Greenberg, they did a pilot study with nurse anesthetists and anesthesiologists, and my limb is going to be working with trainees, so anesthesia residents and student nurse anesthetists. So I'll look forward to sharing that information with you.
I think that's a little bit of a telegraph to next year's meeting. So looking. Other questions in the audience?
Yeah, so feel free to raise your hand if you want to get in the queue. This afternoon, Dr. Beard is going to be coordinating, and Lynn Reed, our breakout groups. And we've pre-prepared some guidelines or recommendations, so to speak, for the breakout groups to consider, which you're free to tear up, say they're great, totally support them, or modify. But to kind of help prepare us for the breakout groups, you talked about some overarching principles that you could apply to all of these locations. I wonder if you might kind of help feed those breakout groups with what you might suggest for those overarching principles.
I seem to be the first one who keeps, okay. In tidal CO2 monitoring. I mean, we have a group in SAMBA that's looking at the various recommendations and guidelines by the dental state boards, and very few of them recommend in-tidal CO2 monitoring, and almost all the ones that do, for example, say when it's feasible. And I'm like, when would it not ever be feasible to do in-tidal CO2 monitoring for a dental case? I mean, is it ever not feasible for us to ever not do in-tidal CO2 monitoring? I can't think of a case it's not. Even plastic surgery on the face, you jerry-rig something and you kind of stick it somewhere and you do in-tidal CO2 monitoring. So I would say that that's just an absolute necessity for any level of sedation, I think we should start being a requirement of the ASA for, minimal sedation, because we all know it's a spectrum, and what one person calls minimal, somebody else is going to call, moderate or deep sedation. And the patients easily sort of move into that spectrum. And just like, it seems to me, every time I sort of hear these, med-legal presentations or cases or things, it often gets down to unrecognized ventilatory depression. And, someone then intervening too late, and then someone not, being prepared to manage that difficult airway or that unrecognized airway issue. And most of these patients survive, they just have anoxic brain injuries. And we know that pulse oximetry is misunderstood and people rely on it too much. So I would just say that's a really quick and easy one. Just everybody, I almost want to walk around with my entitled CO2 monitor so that when I fall asleep in the Uber on the way home, I'll have it.
Anyone else from the panel have additional?
I think I alluded to it earlier, and that is, again, one of the things we as medical professionals don't appreciate is that if you're looking at specifically dental offices where non-anesthesia personnel, non-medical personnel are providing care, then there needs to be people trained in ACLS, PALS, and resuscitation, basic stuff. Right now in a lot of these offices, it is the one person, the oral surgeon, or the dentist with the anesthesia permit who has some sort of, presumably they're up to date with their PALS or ACLS. Interestingly, the California, that's a whole nother thing. That was actually trying to be, there was a push to try and remove the ACLS training for sedation through the California Assembly by the California Board of Oral Surgeons. We shot it down through the CSA, but there needs to be, so again, not thinking about who you have in the room with you and who is able to assist you. There needs to be, it doesn't have to be another medical professional, but somebody else needs to be trained to at least help if bad things happen.
Besides the standard equipment and monitoring that the ASA, we talk about non-OR locations, I think the biggest question I'm asked in conferences all over the world is, can you tell us what would be the proper patient selection for this location? So I think that that would be a very hard answer for one blanket statement for all. The way I think this would be circumvented is the idea that, let's say, implement a patient safety standard, a patient selection standard protocol. And then if you divide it up into hospital outpatient, freestanding ASC, office-based. And then when you talk about office-based, you can talk about mobile office and standard office. But what I think the guidelines, the issue that people will want to know is, where do I begin to say, should this patient be done with this procedure in this location? The reason why I say this is what you saw and what has been validated by the practice is the types of procedures that are going on in the hospital and the ambulatory surgery center and the offices might be similar, but the patients are going to be different, and the amount of emergency equipment, resources, personnel, transfer, hazards, things of that sort, all the things that you can think about. So what I would suggest is having the idea of proper patient selection, and then for each group go into some basic ideas of which would be acceptable for each location.
Just to follow up on that, I think it may be hard to give really hard and fast, sort of across the board guidelines of proper patient selection, but I think you can start with these patients are acceptable, and I think you can define, certain patients that are acceptable, and then I think you can define those who are unacceptable. And then, in the middle, you can say, well, there's a spectrum, and then depending on these, this, or whatever, find where you lie on that spectrum. So for example, if you maybe be able to manage more difficult airways, if you happen to be working in an ambulatory center or a NORA-based place where you have a lot of ENT professionals, or you have Bossum, working with you, as opposed to, someplace else. So I think that it is important, and people do want to know that. And I think sometimes it's just almost too much to tackle to sort of say 100% this is good, this is not. And so I would just start with, kind of like, these are acceptable, these are not acceptable, and then in this spectrum. And again, I think it gets down to that risk of people actually trying to look at this specific risk as opposed to just this, like deer in the headlights. Oh my gosh, I've got an old, sick, elderly patient. What am I going to do? And again, if it's cataract surgery, if they can lie flat, I think they're good to go.
When I polled my colleagues in the mobile anesthesia community and I said, at what age would you do a pediatric case in doing a mobile anesthesia practice? This is around the country. And the consensus is nobody would do a patient under 2. So I agree with Bobby Jean, and I think that we can define which patients are acceptable and which are not. And then the individual aspects would be depending on who's there.
We have a question from Dr. Dutton.
I think the question was about organizing principles for our recommendations, and I'd like to start at the very top, that anesthesia professionals should own this space in the same way that cardiologists wrote the standards for ACLS, that the trauma surgeons wrote the book for trauma care. We should own procedural facilitation for the whole spectrum, whether we are there personally doing it or whether we are creating the standards for patient triage, training, documentation, quality improvement, et cetera.
Anybody want to cover that?
That would actually be on my wish list, is that every single board of dentistry in every single state has a board-certified physician anesthesiologist, at least one, and preferably more anesthesia providers as part of their board structure that helps oversee things like anesthesia and sedation in the dental space. I think that's a huge fight, but just like JACO mandated that anesthesiologists need to be in charge of sedation committees in hospitals, the same should be true outside. And I think it would be enormous. I think it would really go a long way towards helping decrease morbidity and mortality. That would be one of my things on my wish list.
Back in there.
Just a comment about the guidelines, as you were alluding, that we need to kind of look forward to the afternoon of that. Being an office-based practitioner, I would advocate that not everything that might be needed or required at NORA is going to be needed in an office-based setting. So I do think that some of those guidelines and recommendations might need to be separate out because it is a different space. It's a different world. Another comment on just patient selection. I mean, the beauty of office-based, I know in NORA, like one of the presenters said, he doesn't get to pick his patients. Well, an office-based practitioner, we do get to pick our patients. And that's a huge key, I think, in that saying this is appropriate and this is not. And I do totally agree that we need to be at the table for these guidelines on a national level. I have so many parents and patients ask me about, well, what do you do in an emergency? Or what's different between this anesthesia and the anesthesia that I would get at the hospital? And I say, well, I'm the only one there. But other than that, I'm bringing the same things that I would have when I worked at the hospital. And that should be our standard. We shouldn't be doing different anesthesia in the office than we're doing. We should have what we need and have the resources other than people, but we've got the medications, the equipment that we need, and we need to be at the table to make sure that the people doing the anesthesia have those same things.
Anybody want to respond to the comment, or I think it's self-entitled? Yeah. Okay. Next question.
Yeah, hi, Amy Vincent at Boston Children's Hospital. Great panel, by the way. I wanted to add in to the recommendations, perhaps the role of the anesthesiologist in creating systems where people can go without anesthesia where that's appropriate, without creating gaps in our day, and without having patients lose their slot. We did this at Boston Children's Hospital. What we did was created a try without system. We worked with radiology and child life, and so patients who were scheduled for an MRI could come in a week or so before, either at that facility or at one in the suburbs, and try it without. This was for MRI, and we'd work with them. We had a little model MRI they were to see and that sort of thing. Many of them were able to go without anesthesia, and so what we ended up doing was we significantly decreased our wait time for an MRI. We have basically maintained the same volume of cases throughout, and we've been able to weather a significant staffing shortage without any interruptions in MRI care or increasing the wait time. And radiology loves it because they're essentially getting more scans done. The parents love it because they're able to go without anesthesia without giving up their slot. And we love it because we're not having these big, great gaps in our day when a parent comes and says, actually, I think we would like to try it without today, which, of course, we would never force someone to have anesthesia. So it's been good across the board, and I think it's one of those things where we as anesthesiologists could advocate for people, quote unquote, trying without in a way that doesn't interrupt our workflow.
I think that's a really excellent point in trying to get out to the other providers. I think increasingly, particularly in people who are being trained, sort of currently or in the recent past, as, proceduralists, they've always sort of had these patients having anesthesia. And so it's just assumed that everybody needs anesthesia. And in fact, I have to tell you, many times I find that I'm frequently, having been called upon to take care of patients who don't want to have anesthesia. Because even the anesthesia providers are like, there's no way they can do that without anesthesia. There's no way. I'm like, they just need a little TLC, some being warm, somebody talking to them, somebody being there and prepared to give them something they needed. And I do believe we may be some of the problem. And I mean, not to pick on oral surgeons, but one of my daughters had to have her wisdom teeth taken out. And the oral surgeon told her when she first met with him, and she was an adult, that she had to have anesthesia. She had to have sedation, or he was not going to do it. Because he was afraid she would move and injure herself and sue him. So I met with him. We had a little conversation. And he ended up doing her with her wide awake. She didn't move. And he later, to his credit, said we changed his life. He was a relatively young guy. He was, trained in a trauma center, and he had just never had that experience. And he took care of mainly sort of this, sort of perhaps a different population of patients too, and that, maybe couldn't fully understand what was the situation. So I do believe there's this whole role for us to advocate for no anesthesia.
Working in an eye center, I've learned that concept very well. Being an anesthesiologist and an interest in intravenous anesthesia, I've learned from the ophthalmologists that they're now doing more topical anesthesia, and you say, do you need some medication? They say, if the patient needs it, sure, but if not, it'll be okay. So I've learned how to say, that's okay. But that's something that we have to learn, I think, as a group of individuals. And I think to echo what Bobby Jean said about, talking to the proceduralist or having a patient advocate. I had my own experience with my niece who was in her early 20s, and she had to have her wisdom teeth extracted. And they said she's going to have intravenous anesthesia and nitrous. And I said to my sister, I think this is overkill. And I said, knowing what I've described to all of you about 20-somethings in wisdom teeth in dental offices, and the proceduralist didn't have an anesthesiologist. So I said, well, why don't you just give her something to relax her at home and have him do local anesthesia? And so, because that was what her anxiety was, and so they gave her some Ativan, and my sister went with her, and she had local anesthesia and did fine. And she said, well, why doesn't everybody do this? I said, well, we just have to re-educate ourselves and learn that this is okay.
So, since we're talking wisdom teeth, there's actually a reason. One is that the anesthesia bills more than the actual procedure. And so there's a real, again, not to pick on oral surgeons, but there's a real incentive to actually provide anesthesia. And just to finish the other end of the spectrum, when my son had his wisdom teeth out, we had an anesthesiologist come in to the office. I chose an oral surgeon who worked with anesthesiologists. They did their own sedations, but they also worked with an anesthesiologist. So there are a lot of different ways to do it. And I still remember when I had my wisdom teeth out being offered a choice of sedation versus no sedation. And I ended up, and my mom let me choose. I ended up choosing sedation because at the time I kind of thought I was going to go into anesthesia. I thought it would be good to know what it felt like. So, I mean, there's also, I mean, we can't be, we can't get away from the fact that there's also a monetary incentive in some cases. Not for us, I think, specifically, because we're all, I don't know, we're all so busy all the time. But there's that part of it too.
Just explain the alternative. So I'm an anesthesiologist, for those of you who don't know that, and I've had 3 babies, 2 colonoscopies, my wisdom teeth, and a breast biopsy with no anesthesia. Because I wanted to know what it was like to have no anesthesia.
The other side. One more question. Yeah.
Hi there. So my name is Charles Lynn. I'm from the University of Pittsburgh. And because of your information, I think I will not have any of my kids get any anesthesia without me being there because it frightens me. But all joking aside, so my question for you is, I'm at the University of Pittsburgh. I think many of us work in an academic setting, right? At least with dental procedures, many of them are not affiliated with an academic setting. So the pithy saying, which is, you don't know what you don't know. So obviously, regulatory, from a regulatory standpoint, we can compel people, practitioners, to do certain things. But for many of these people who are out in the community, they're not affiliated with an academic center. What are your thoughts on how we could convince them that, yes, in fact, their staff needs better training so that they see that there is a need and that we could potentially be a source of information for them when they come to us?
So it's really tough. I mean, I spent a long time, I spent a lot of time in Sacramento and California trying to have these conversations with both the assembly people and the senators there, having the conversations with the dental lobbyists and the dentists. And there's definitely some who are very fixated on the fact that, and this is true, they have been doing this way for decades. And really, the vast majority of sedations that they do are perfectly fine. So trying to convince someone that something that maybe they haven't experienced in their own practice or even someone they know or care about is wrong. This is indoctrinated in, this is what they're taught. The oral surgeons spend 5 months doing OR anesthesia now, plus a lot of time doing office-based anesthesia. Dentist anesthesiologists are dentists who've done who finished dental school and now do a 3-year residency. They understand a lot more of these issues, but it's very difficult until you have, unfortunately, a lot of these catastrophic things occur. I will say in the state of California, since Caleb, even though we weren't successful in getting part 2 of Caleb's law through, there's definitely been an increase in the number. First of all, we're seeing a ton more dental anesthesia cases at Lucille Packard Children's Hospital where I work. The volume has increased, and that's true, I think, across the area. There's been a huge increase in the number of specific dental anesthesia practices across the country. There's Smiles MD, and there's dental sedation groups. There's a whole bunch of groups now that are increasing. One of my former fellows went up to Oregon and started a group there where that's all they do is dental anesthesia. And as dentists, and I think one of the proceduralists said this morning, once you've had an anesthesiologist there or you've had a separate anesthesia person providing care to your patient, you kind of don't want to go back. So, I mean, part of it is just continuing to hammer on, but you don't know what you don't know, and trying to convince, especially some of the older oral surgeons, that, you know, telling them what they've been doing for 30 years is wrong. That's just a no-win situation. So we continue to try and educate. We continue to try and point out the benefits of doing it a different way.
So let's go ahead and break for lunch. I know there's other questions, but you can ask them. We'll reconvene at 12:30. Thanks again for a great panel. Again, if you have questions, the panelists will stay around. Thank you.